Good afternoon, everyone. Thank you for finding time to join early in today's session. You're most welcome for today's nursing series webinar. And we are already a quorum, so we'll straight away start. And today I am your moderator. My name is Ruth Nyansikera from Nursing Standards at Kenyatta National Hospital. And we are privileged to pursue further a topic that we have had a few sessions before. And this is a topic of great interest to the nursing profession. This is on the wound, ostomy, and continence care, generally speaking. But specifically, the topic for today is special techniques in wound, ostomy, and continence care management. So feel most welcome. As the numbers increase, we are happy to have you on board. We want to allow the convener or the organizer of this particular topic, Dr. Peter Mwiti, if he is present, to just say hello as we start. Dr. Mwiti, are you present?
Yes, I'm present. Are you able to hear me, Naskela?
Yes, we can hear you loud and clear. Please go on, say hi, introduce your team.
Okay, thank you very much, team. My name is Dr. Mwiti, Head of School of Nursing. With me, I have Mary Ikalia, who is going to present us. What is very important is that to know we have expertise in Kenyatta National Hospital who are dealing with the healing of the wounds. They have good knowledge and skills on application of the wounds for quick healing. Therefore, and we train also in Kenyatta National Hospital and other staff from different counties in the country. Therefore, in case you are interested in your team to be trained on wound and ostomy care, we are in the School of Nursing and we have 3 entries in a year, which you will hear more by our presenter. Thank you very much. Welcome and enjoy the presentation. Thank you.
Thank you, Dr. Mwiti, for that introduction of the main presenter for today. Mary Karia is a senior nurse whom I have personally known for many years at Kenyatta National Hospital and is very passionate about wound care and is quite knowledgeable and experienced in that particular field. And we are saying that when it comes to matters wound care, then the nurse needs to know the right materials to use for the right type of wound, and hence the selection of this particular topic of very much interest, special techniques in wound, ostomy, and continence management. So I want to just remind us that we will take questions and comments as we go along. Should you have any of these as the presentation is going on, kindly chat them, send them in the chat box. We will pick them and respond to them probably at the end of this presentation. So at this juncture, I want to say, Mary, you're most welcome. We are happy to have you. I think now it is you to go ahead and just tell us more about this topic, and we are ready to learn. Karibu sana.
Okay, thank you so much, Ruth. And thank you for giving me this chance to enlighten my colleagues on what we do best on wound, ostomy, and continence care management. It is a wide topic, but I've just tried to pick the specifics because this is a topic that includes three areas of specialty. That is wound care, ostomy care, and continence care. And I'm glad that I'm given this chance to educate many people throughout the country so that those who are interested can join us in our training, and we'll give them the course, which is 3 months and 3 intakes in a year. So I'm proud of being part and parcel of Kenyatta National Hospital. That is why I've started with that slide to show where I work. I work there in the School of Nursing. A little bit of introduction. Due to lack of specialized care, patients have suffered. They have felt neglected and left alone to cope and also this also affects the nurses. When this patient comes to you and you have no knowledge of what exactly to do with this patient, you feel affected either positively or negatively. We usually see some patients shying off, and also the nurses, due to lack of specialized training, so they get shy off when they get a patient with these 3 issues, which are very traumatizing and need a lot of support from our side as carers. So this specialty is all about managing patients with fecal, urinary diversions, drain wounds and complicated wounds, and also complicated fistulas. With the advent of stomach wound and continence education, changes of management of stomach wound and urinary continence have taken place here in Kenya. The first education program was started in Aga Khan. That was 2013 by a team of nurses from Australia, sponsored by the Australian Enterostoma Association. And so the Aga Khan was the convener. At that time, we were 53 of us. And in Kenya, we trained 49. The other 4 were foreigners. And we were privileged in KNH to be trained 9 of us. At the moment, we have picked up in KNH with that program of 3 months. And so far, we have trained 112 students who are out there assisting our patients. Then let's go to the topic. What is wound, ostomy, and continence care? This is a multifaceted specialty which deals with wounds, ostomies, and continence issues. And we focus on healing wounds, managing stomachs, and supporting bladder and bowel control. So you need combined skills and emotional support to be able to take care of these patients. Our goal is to restore dignity, comfort, and quality of life to our patients. So we have specific roles for somebody trained on wound, ostomy, and continence specialty. These people are nurses, but in our training, we are incorporating all clinicians. So we have trained people who are not nurses, and they are taking these roles very well. So our role is to do clinical assessment and intervene and make our patients individualized plan of care. Then we have patient and caregiver education. That is very key, because if you don't train the patients and the caregivers, you will not be able to achieve your goal, because they need to do it at home. Prevention of complications. There are several complications that these patients get. And also, we do product selection and fit them the way they are supposed to be done. Advocacy and policy development, we assist in that so that our patient can get the best. We are also involved in research and evidence-based practice, because all what we have in wound, ostomy, and continence is evidence-based practice. So I'm going to take each part of the specialty, that is wound, ostomy, and continence, and talk a little bit on it. In wound care techniques, we have several things that we have to do, a must do for you to make and attain your goal. One of it, you have to know how to do wound assessment. You know how to prepare the wound bed so that the wound can start healing and closing. We also have advanced therapies like negative pressure wood therapy. We also need to maintain the moisture in the wood so that the wood healing can take process. And also we have advanced wood dressings. When we come to wood assessment, we have to look at the patient as a wholesome. We usually say, don't just see the whole, which is the wood, but see the whole patient. So you do holistic approach. We are assisted by a NACROM timer to do our assessment so that we can assess our tissue. I'm not going to go into deep because the topic is too big. I cannot be able to explain, but maybe in another column we'll do that. You have to check what type of the tissues you have on the wood bed so that you can be able to make a decision on what is the priority. Is there infection in that wood? And treat it if it is there. Moisture, the wood should be moist, but not dry and not so wet. The edges plays a big role in wood healing, but most of the times we ignore checking the edges. The edges should be healthy and advancing, because you'll find that some of the patients will have some edges which are lolled and others which are laced. And when there is lolled or laced edge, the wood will not progress. Then there is repair and regeneration. This is where we use types of wood dressings that help to fasten the healing of the wood. And also we have support system. This patient has to have a support system so that they can be able to be taken care of. They can be able to access and buy their products which are needed. So they need a good support system for them to progress. That is just a chart that I decided to put there, just to show you what you can do in your institution. You can have a wood care assessment chart so that you can be able to monitor your woods well. Then when we go to wood bed preparation, this is where you have already determined what type of the tissues are on the wood bed. So if the tissues are slab or necrotic tissue, which is non-viable tissues, you have to remove them. And by removing them, you do debridement, which is removal of the dead tissue and the infected tissues. And this one will make way for healthy tissue to grow. And this can be done in different ways. Sometimes we use special dressing like hydrogels, and that we call it autolytic debridement. We also do other debridement using tools, like when we take our patient to theater for surgical debridement, or when we are doing conservative surgical debridement at the bedside. Use of natural enzymes, you have some gels and creams that do enzymatic debridement, where they digest the dead tissues, and then when you are cleaning the wood, you wash them out. We have a special treatment called maggot wood therapy, where we use maggot larvae and we introduce them to the wood bed, and they clear all the dead tissues, and your wood is left clean to progress. That is just a diagram to show the types of tissues you can find in your wood. You can find healthy tissues, which are granulating tissues. You can find healthy tissue which are ectorizing, and also you can find non-viable tissues, slab or necrotic tissue. And that is where wood bed preparation comes in, and we debride the slab and the necrotic tissue. A special advanced treatment of woods is negative pressure wood therapy. And when I think of negative pressure wood therapy, I usually think of like a gentle vacuum cleaner for the wood. You use a special device which has controlled suction the wood through a sealed dressing. It is not as a complicated procedure, but you have to have some knowledge on it so that you can be able to perform it. This one benefits deep infected or slow healing wounds. But there are some wounds that we don't apply negative pressure wound therapy, like a patient who has untreated a wound which is involving the bones and he has untreated osteomyelitis, a wound that is having a breeder that you have to do some investigations. So those are some of the kind of wounds that you'll not use a negative pressure wound therapy. The negative pressure wound therapy will help us to remove infection, that is the bioburden. It will keep the wound clean, and it will encourage growth of new tissues, that is the granulation tissue, so that the wound can fill and start contracting. It promotes contraction of the wound, and also there's something I've not written there, but it also helps us to reduce oedema. Then the recommended pressure when you are doing negative pressure wound therapy, we recommend 75 to 125 milligrams of mercury. So that's why I've said a specialist or a skilled person is the only one who is supposed to do this because of controlling all the pressures so that we don't harm the patient. I've just put that photo there to show you what we used to do before. Before, when I was training, we used suction machines to do our negative pressure wound therapy. But at the moment, I want to appreciate our institution that they have procured the light vacuum dressing machines, and we are using them perfectly in our clinical areas. That diagram just illustrates a wound on negative pressure wound therapy, how it looks like. And then the diagram illustrates that you can be able to use one negative pressure wood machine on two different woods. You just need to do a bleach and protect the skin where the bleach is, and you'll be able to sanction or to put the pressure on two separate woods. Then when we come to wood, moist wood healing, this is where I said the wood needs to be moist, not too dry, not too wet, just the right moist. We keep this wood moist so that you don't get soggy on the wood, because if you get soggy, the wood will macerate. And this moisturizing of the wood helps the cells to grow fast. It also helps us to reduce pain and scarring, especially when we are removing our dressing from the wood. If the wood was so dry, it will hurt the patient. And so we recommend just the light moisture. Also, we have advanced dressings that are perfectly used to create perfect environment for the healing. Some of them, they donate moisture where the wood is dry. Others, they absorb moisture when the wood is too moist. And others just helps to control the moisture in the light moisture that we need on that wood. Some of the advanced dressing that we have, they help us to absorb fluid where we have excessive exudate. Others have medication, and they release the medication to the wood to control infection. Some of them, they have a way they change in color, and that tells you, it communicates to you that this dressing is ready for changing. Others will reduce infection and protect the fragile skin so that the skin is not macerated and the wound does not extend. Other dressing materials will conform to the wound. That means it will conform to the shape of the wood so that you don't leave a gap between the dressing and the wood bed, because when there's a gap between the dressing and the wood bed, the exudate will soak there and the wood bed will be macerated. So we have smart targeted healing tools that helps us to advance the healing of the patient if they are used if they are used well. So that diagram just illustrates how what we used to do many years ago. We used to use the gauzes and the strapping, but at the moment, with advanced wood techniques, we have several bloods of wood dressing materials, and I thank our institution for procuring this for us because it has made our work easier. You can see several of them. They come from different companies. You can see the Inadine, Actisoap. We have the AMDs, the Aquacell. All these are from different companies, and they help us a lot because we don't have to do the usual wood care that we used to do, a daily dressing or a PLN dressing. Some of this dressing can stay on the wood even for 5 days without changing, and then you change it after 5 days. I put that to show us before we did the training and we got the advanced wood dressings. A patient from theater looked like the diagram, the first diagram, full of many gauzes which are soaked. And afterward, we have advanced to advanced wood care products, and you can see how smart the patient comes out from theater looking. That other diagram just illustrates for us the way we used to use the gauzes, and we used to do daily dressing, PLN dressing, but with the advanced wood dressings, you can see, as you can see there, you can even address the next person who's coming to take care of the patient on when the wood is due for changing, or if the wood is exudating much, they can change it if it becomes wet. So you can be able to give even instructions on the dressing itself, and the next person who is going to take care of this patient has instructions written on the dressing. We come to our second part of the specialty, that is the wood, the ostomy care, and you can see a little bit of some of the techniques we use. As I said earlier, I will not be able to elaborate everything, but I'll touch in some unique areas. For ostomy care, we have customized stomach appliances, whereby each patient is unique and individual. So you do the assessment individually and make a plan of care for individual patients. So what one patient can use is not the best for the next patient. So you have to do a thorough historic approach so that you can identify what your patient needs. Then in stomach care, skin barrier protection is very, very key, because if the patient excoriates their skin, even applying that bag will be a big challenge. So let's see the two areas. As I had said earlier, every stoma is unique and it is tailored to fit each person's unique body, shape, skin type, and lifestyle. So each patient can use we have different types of appliances, and different patients use different appliances to fit them. This one will ensure that the patient is comfortable and there's no leakage of the effluent from the stomach. As nurses, specialized nurses, or nurses with the skills of stomach care, they'll be able to assess this patient they'll be able to cut the stoma into the shape and the size that is required, and also will be able to apply the stoma bag appropriately so that it doesn't leak. So, like tailoring the clothes for a perfect fit, each patient needs a perfect fit so that they are comfortable with their stomach. I have just put that diagram there to show us some different types of stomach bags and accessories that we use in stomach care. As we can see, the bags are in two types. We have a bag with a flat base, and we have a bag with a convex base. These two types of stomachs are different, used differently. These two types of stomach bags are used differently. As you can see, there's a bag there. The first bag on both sets is a closed bag. That is the perfect bag for a colostomy. The second bag is a drainable bag, which is a perfect fit for an ileostomy. And the third bag is a perfect bag for urostomy. In our situations, we usually use the second one, mostly for the stomachs, both the ileostomy and the colostomy, because it is drainable and it is cost-effective to our clients. Because the patient can stay with that bag 3 to 5 days, they'll only be waiting for the bag to reach half to a third to a halfway full, and they drain whatever is inside, and then they close their bag, and it stays there for 3 to 5 days. That is so economical for our patients, knowing that the bags are not so cheap. I think the cheapest quality bag you can get is allowed 500 shillings in the market to 1,000 shillings, depending on where you are looking for it. So we usually advise our patients, educate them, so that they can also be economical because of the prices. The next diagram there is about accessories. Accessories are things that we use together with our stomach bag to make our patient comfortable, to make our patient not escalate the skin, to make our patient not to leak effluent, and to make our patient comfortable to go ahead with their social life. Because when the patient has this stomach, their social life continues. They can be able to go swimming with others. They can go to social places, church, groups, and they can go for sports. And with the help of the accessories plus the stomach bag, our patient is comfortable to do their social work as usual. This one is just illustrating the kind of patients we come across. You can see in the first diagram, because of economy and lack of knowledge, patients are also innovative. You can see how that gentleman had innovated a bag there, and life continued for him. But now when he came to our clinic, we were able to educate him and provide some bags for him through the support group to use them, and we encouraged him to join the support group so that he can get more education and get some supply of bags, though we only supply bags when we have availability. The next diagram is another innovation. You can see how that gentleman also innovated a baby care container. He had put some 2 strings to tie at the back so that he keeps it in place. And you can see what we did for him. He went home a happy person with education and some surprise of stomach care bags. And we also encouraged him to join our support group, that he will get more education and life will be easier for him with a bag. You can see the third patient here. He was also innovative. He used what was available for him. We also did the education, and we did apply a bag on his stomach and educated him to continue following up in the stomach support group for more education and supplies of bag when they are available. Let's talk about the skin protection. It is very crucial to protect the skin around the stomach. As I had said earlier, if the skin is not healthy and intact, it will be trouble for you as the stomach nurse, the patient, or the carer. Because for one, the stomach bag will not be able to hold on a skin which is oozing some fluid, so it will keep coming out. And as it comes out, it will continue worsening the skin around the stomach. So for that, we go back to our accessories, and we see that some of the accessories that will help us to keep the skin protected. We have special powders. We call it stomahensive powder. We have some creams that you can use, especially if the patient is not using a bag, so that it will protect the skin. We have some links. They help us to protect the skin and to make the bag adhere to the skin so that there's no leakage around the skin. What we advise our patients, immediately a bag starts leaking, it is time to change the bag. Don't force it to stay, because you'll get escalation of the skin through the effluent that will be leaking under the bag. So when we have these barrier protections, they help us reduce irritation and help us to stick the appliance or to adhere the appliance, that is the bag, on the skin, and the patient is comfortable with that. This helps us to maintain dignity and comfort. There's nothing that disturbs a patient like a leakage. Most of the patients, they have stigma because of leakage and discoloration of the skin. Especially when there's leakage, the patient not only have stigma from the people they are staying with, but they have self-stigma, and they feel that they are not themselves, they are not worth. So we need a lot of counseling to comfort this patient. And the best we can do for this patient is to solve this problem of leakage. It also improves when the patient is comfortable with no leakage, with no excoriation of the skin. They improve their self-esteem and quality of life. And you have a happy customer, a happy client, a happy caretaker, and a happy stomach wound and continence nurse. The other thing we do specific for stomach is the stomach education and counseling. As I have mentioned earlier, the class of patients that we take care of with stomachs, they are emotionally stressed, psychologically stressed, financially stressed, and some even spiritually stressed. So we need to give a lot of emotional support, involve counselors, and most of us who are specialists, we have to have that skill of counseling, because we do a lot of counseling for these patients to live a comfortable quality of life. Teaching patients how to take care of their own stomach is the best thing you can do for them. We should not let this patient be independent always, unless they cannot be able to do it. So we teach them on how to take care of their stomachs, how to take care of their skin, and how to identify complications and report early so that we can take charge. When you're teaching our patients, we talk about the diet, we talk about how to apply the bag, we talk about the emotional support. We also involve this, the relatives or the choice, the person that this patient chooses as a support system. We involve them in this learning so that they can be able to help our patient to have their self-esteem back and quality of life when they go home, because most of them, they go home with a stomach. Since the earliest the stomach can be refashioned is 6 weeks. So some of them, they stay with stomachs for more than 6 months, 1 year, and then they come back. If it was a temporary stomach, they come back for reversal. And if it is a permanent stomach, you have to teach them to accept and live with it. And most of the patients, when they are educated well, they live a very comfortable life, even with a permanent stomach. So this, by counseling, will restore confidence and independence to this patient. Wound ostomy care therapist will teach the patient how to care for their stomach, how to manage their diet, how to dress confidently, and to regain control over their lives. When it comes to diet, we don't have a special diet for stomach patients. We advise them to take a diet that is a complete balanced diet. But as they introduce, after theater, as they introduce themselves back to the diet, they should introduce one thing at a time so that they can observe whether there is something that is going to affect them. When it comes to dressing, we advise our patients to dress in a way they are comfortable, but make sure that obstruction of the drainage of the efferent is taken care of, especially when it comes to teenagers. You know, our teenagers, the way they like dressing, don't discourage them. Just give them, advise them to take caution that they don't obstruct the output flow of the stomach. And then when this patient is well educated and mingles with others who have stomach, they take up very well and they take control, they take back control of their lives. Continence matters. Incontinence is another stigmatizing issue. Many of us and our relatives are suffering from incontinence silently because it looks like a taboo to talk about matters of toileting and passing stool and passing urine. So you'll find that many of the clients who have these problems, they don't talk out themselves to get help. So as a stomach wound and continence nurse, I usually advise when you go to your groups, the church groups, the chama, and any other social groups, just introduce a small topic on continence. And you'll find out that so many people survive with continence issues silently. So how do we help these people? What we do, we train on bladder and bowel training. We creating routines to regain control. For those, especially for the elderly, the ones with the cognitive issues, it is good to create a routine whereby they are reminded to go and empty their bladder. That way, we use a scheduled timetable for that. Sometimes you can use signals if it is for like children who wait at night. There are some signals that you can attach to their inner parts that immediately they start leaking the urine, it alerts them and they are able to wake up and go and to the toilet and do the necessary. Coach the bladder to behave better over time. Sometimes we are the ones who mislead our bladders. For instance, how many of us, when they are leaving their house, just go to the toilet, not because they have an urge, but because they just want to say like, let me just go, just in case I'll not be able to reach where I'm going without having an urge. That's doing that misleads our bladder, because our bladder is put in a way, in a system that it will detect when it is full, set the signal to the brain, and the brain sends the signal back to the bladder. And especially when you have already identified the right place and at the right time, the bladder will not open until you reach a place you can help yourself. But if your bladder usually open before you can identify a washroom, go in and do the necessary, you have a problem. And it's a problem that can be rectified. And many times we have found people tell each other that is like now in reproductive age, you hear mothers telling each other that is something that is normal in that stage and time. No, it is not normal. You need to be directed on what to do so that you can be able to control your bladder the right way. The other thing that helps is about pelvic floor exercises. So when we are taking care of these patients, we work hand in hand with our physiotherapists so that they can be able to train our patients to do the bladder exercises. And these exercises will strengthen the muscle and prevent leakage. And especially, it is very helpful to the postnatal mothers, that is the reproductive age, and the elderly patients. Most of the times, it is just a laxity of our muscles that makes us leak urine. And when we go for these exercises and we are taught how to do them, the problem is solved. I know most of us may think that incontinence is only when you pass urine without control, without even feeling it. But no, when you go there and you are laughing, you are sneezing, you are trying to lift something, and you leak a little bit of urine, that is incontinence. So I know many of us have that problem. Let's look for help and something that can be rectified. For those who have issues that are not medically rectified, we try to improve their quality of life, and there are continence products that they can use comfortably and continue their life comfortably. So we use continence products on person who cannot control the flow. They are supposed to be pressed carefully to avoid infection, especially when it comes to things like catheters. You have to be very careful and maintain the sterility so that you don't introduce infection to our patients. Some of the products that we use for continence is absorbent pants and panties for ladies and for gentlemen. We have disposable ones, and they are those which are reusable. We also have absorbent bed pants and chair pants. Those ones, we use them on the bed and on the wheelchairs, that when the patient leaks, it will be able to absorb that urine and contain it so that the patient is not lying on a soggy bed. We also have panel sheds for men. Those are the ones we use in the wards, the ubicodoms, whereby you can even teach them, especially those who are at home care, to insert them and use them. Then we have the catheters and collective devices. That is collective devices like bedpans, urinals, and catheters. We have them in different sizes, for different classes. There are those for ladies and there are those for gentlemen. The diagram shows us different types of urinary continence products. You can see we have the pads, and we have a light pad, and we have another one which is a bit thicker. We have the diapers. We have the other pads or the bed pads. We have the urocodoms. We have the catheters, and we have panties that are padded, heavily padded, so that when you leak, especially when you're coughing, when you are lifting, it can absorb. We also have panties that are leak-proof, and they are available in the market. So ladies, we are taken care of. Don't shy off. Maintain your quality of life by using some of these products that will keep you dry and comfortable. Then we have lifestyle changes. Fluid and diet adjustment. When it comes to fluids, if you have a patient who has incontinence problem, it is advisable to advise them to take a lot of fluids during the daytime, but control in the evening, so that they don't come out of bed now and then to the toilet. When it comes to diet, we advise them to avoid spices. Diet with a lot of spices, diet that contains nicotine, like tea, Coca-Cola, cocoa. They try to control and take them minimally, because they will irritate the bladder and they'll get the incontinence problem worsened. Toileting routines, as I had said earlier, for those who have no control completely, you remind them to go to the toilet at a time scheduled timetable. It is important to empower our patients to manage their contents so that they can own the problem and they can have their self-esteem back and they stop stigmatizing themselves. The human touch in wood, as I'm concluding, the human touch in wood ostomy care, it is a special care, and it is not just a tool or a technique, but the heart behind it. If it doesn't come from your heart, you'll not be able to take care of this kind of clients. So it has to be passion in it and willing to take care of our patients. It's more than just a procedure, but it connects us with our patients. We try to preserve dignity in very vulnerable times. As nurses and caregivers, we guide our patients with empathy, skills, and patience. These are patients that need a lot, you to be there for them, you to be patient, because they'll come many times to consult on issues that are disturbing them. They need your care, they need your comfort, they need emotional support. Let's do it for our patients. It's all about healing with skill, empathy, and respect for our patients. All in all, we face some challenges when we are taking care of these patients with stomach, with the wounds, with continence issues. And some of the challenges that we get are limited access to specialized services, to supplies, and low resource, especially in the low resource settings. The clients who are within Nairobi and some of the cities in Kenya, they are privileged that some of our chemists provide these, have accessibility of some of these products that we use. But those who are in the peripheral, the interiors, it is hard to get these advanced products for their wounds, for their stomachs, and also for their continence. But luckily, we have some companies that even a person who is very far interior can be able to talk to them, to purchase, and their package is sent to them through a package. They can be able to send to them where they are, as long as there is transport. Stigma and psychological burden are faced by our patients, particularly patients with stomachs and incontinence, and also patients with chronic wounds. I've experienced taking care of patients who will give you a history of their wound, which has been 3 years, 5 years, or even beyond that. And it is so stigmatizing. So emotional support is key. As I repeat, emotional support is key. High cost of the advanced dressings, wound care dressings, stomach appliances, and continence products is another challenge, because most of our clients are not in a position to purchase them because of their economical status. That's why I said support system is very key, so that they can be helped to attain their dignity. Need for another challenge we have is interdisciplinary coordination in complex cases. This is where, when it comes to wound care or stomach care or continence care, we should have a multidisciplinary team, whereby each team member has a role that they play. For example, if I take wound care, we should have a surgeon. The surgeon will take this patient maybe to theater for debridement. We'll have a plastic surgeon who will do the reconstruction. We have a physiotherapist. We have a nutritionist. We have a nurse, and especially a wound care specialist who will take care of this wound until it is clean for the surgeon to do the reconstruction. And don't forget to involve the patient and their carers in this care. They should be team members of this team, so that we can be able to work and coordinate well. The other challenge we have is limited training of personnel. There is resource constraints and low patient education. At least we can appreciate that in our institution, KNH School of Nursing, we are now training personnel for stomach, wound, and continence management. And the few we have trained, the 112, they come from different areas, though most of them comes from Nairobi and its environs. So we still need more in the peripherals. Those who are listening to me, you are most welcome to come and advance in this specialty, because we have so many clients who are suffering because they don't have a trained personnel to help them. They don't have enough education, because we say that is one of the role of a stomach, wound, and continence specialist, to teach the patients, to teach the colleagues, and to teach the caregivers at home so that there's continuity of care of these patients. Last but not the least, I would like to appreciate my institution, KNH, for supporting me and my colleagues to take this training, for procuring and storing the necessary products for wound dressing, stomach care, and continence care, for giving me a chance to share my skills with colleagues through conducting continuous medical trainings, that is CMEs, and for deploying me in the Wood Ostomy and Center to give services where my passion is. For deploying me in the School of Nursing, KNH School of Nursing, to disseminate my knowledge so that many patients can get care the rightful way. Final thoughts. Wood ostomy and continence management blend science and compassion. Special techniques are needed for us to personalize, individualize each patient to enhance healing. Together we can improve life, one wound, one stomach, one smile at a time. Last but not the least, I cannot forget to advertise our school, KNH School of Nursing. We are training a 3-month training in stomach, wound, and continence, which is 3 intakes a year, March, July, and November. What are you going to learn when you come to us? How to manage complex wounds with confidence, expert stomach care, where you give back to the community, to the patient, to be able to control themselves, to take care of their life and improve their quality of life. You'll also learn sensitive and effective continence care strategies. And then you'll do practical hands-on session guided by experienced specialists. Why do you choose that? Why should you choose us? Deep clinical experience in a busy national referral hospital, supportive experts, trainers, and satisfaction to open doors. Thank you so much for listening to me. Questions are welcome.
Thank you so much, Mary. This is a wonderful presentation. Indeed, your expert knowledge is evident, and not just knowledge, from experience. You have gathered a wealth of information that you have really shared and shared with us. What a way to end this session. You mentioned one wound, one stomach, one smile at a time. That's quite a final thoughts. And I am happy that we have as big, the attendance is quite big. We were 602 participants on board today. And I believe you are actually giving your passion the best. Because if you take all these professionals and not just nurses, as you mentioned, wound, ostomy and continence care is not just about one cadre, it's multidisciplinary. So we have everybody on board when it comes to wound care. And now, so now I think we are ready to ask questions, give our inputs. Participants have really appreciated this presentation. I've seen a lot of thumbs up. So we acknowledge that, and we are happy that you were part and parcel of today's presentation. Remember, this is the nursing series by KNH UN, and this is in an effort to empower the health workforce in terms of evidence-based practice. We are here to disseminate nursing knowledge, especially on the first and the last Thursdays of the month when we are having our nursing series. So back to the questions. I see question number 1. We have Lillian Angweji, thank you for your question. Could you comment on burn management and open wound versus closed wound and the frequency of dressing? Any role of use of honey in wound management? I suggest that Mary takes the questions and then she can be able to respond to them one by one. So Mary, please go ahead. Just take note of that question. I'll read the question again. Could you comment on burn management, open wound versus closed wound, and the frequency of dressing? And the participant would also like to know the role of use of honey in wound management. So those are two questions in one, Mary. Just take note of that. Thank you. The next question is from Grace. Thank you, Grace Omolo. You asking about the cost of training and the requirements for training. Mary already answered that question, but should she feel that there's something she didn't mention probably about the requirements, then she can mention that. And I wouldn't mind I hope the participants can hear me. Please confirm that you can hear me. I see thumbs up. Thank you. I consider that as a positive that you can hear me. So we continue with that. And so let's continue. The third question here is from Francis Joseph. Thank you, Francis, for asking. After how long do you introduce another item where you stayed on that one item is introduced at a time? I think this is also to Mary, but I was just going to mention that on this question of the cost of training and the requirements, probably if Dr. Mwiti is still on board, we would like to hear from you, but I think Mary is here and she can go ahead with that. Thank you. So again, we move on to the next question, this is anonymous attendee, which nerve is responsible for sending signals to the brain about full bladder? And this is a good question, quite a lot of physiology there. And if Mugi is present in the house, she's also one of the specialists in wound ostomy and continence care. We would also like to hear from you on that question. I want to pause there to allow Mary to respond to the questions that we have mentioned, lest we be repeating ourselves, because I see some positive remarks on sugar and honey. So again, that's a question that has already been raised. Please raise the clinical questions first, then you'll do the administrative one last.
Okay. So thank you for the question that you have asked. About burns, burns is part of wound care. So I will not address them as separate entity. They are part of wound care. And we know that when we are treating burns, there are different things that we consider, like the extent of the burns, the fluid loss, and when we come now to taking care of the burns as a wound, we will do the general wound assessment, we will do the wound bed preparation, and we will do the selection of the appropriate dressing to help us facilitate quick healing on that burns. For open wounds, we usually have open wounds that are draining, that is exudating much, and we have open wounds that are not exudating much. So for the open wounds that are exudating much, we usually use advanced dressing like wood bags, where everything collects into the wood bag. You are able to check the output, to control, and not to control, but to do input output. And you are also able to control the exudate so that the patient is comfortable and mobilizes. For closed wound, we have different types of closed wound, starting from incisional wounds. We have, so since we have different kind of wounds, as I said earlier, each wound is unique. So there's no one dressing for all woods, and there's no one dressing which is best for all woods. So what dictates us when we are taking care of these woods is the initial assessment that we did. That one, I usually tell my students that woods talk to us. When you do the appropriate comprehensive wood assessment, the wood will communicate to you its needs. If it is exudating much, it will communicate to you that you need to control the exudates. If it is infected, it is communicating to you that you need to control the infection. So each wood is treated individually and uniquely. Frequency of dressing also is dictated by the assessment. If the wood is so exudating, you might be changing the wood dressing in alternate days. If the wood is minimally exudating, you might keep the dressing even for 5 days. Some of the dressing we do even for weekly, especially like for venous leg ulcers, we do compression bandaging, which we do weekly. So it depends on your wood assessment. About honey, honey is used in wood care, but not just any honey. You don't go to the supermarket and buy honey and put in your wood. There are specific types of honey which has been researched and packaged for wood care, and you'll find them in the chemists to use them. Please don't just take any honey from the market, because we know that some of our honeys are not pure. They added other things that can affect our woods. Then I go to diet, one diet at a time. This is where I said about when our stoma clients is reintroducing themselves to feeding after surgery. I said we don't have a specific food for ostomy. We advise them to take balanced diets. And that's where I said one diet at a time. What I meant is there are those foods we will take even in normal circumstance, and they bring bloating to you, or they give you constipation. That's why I say this patient is advised to introduce what they were eating earlier before surgery, but one at a time, so that they can observe. Because when a patient takes diet which is giving him gas or fretters, they get stigmatized. But we usually advise them, you can take this food. Maybe, for example, let me give an example of beans. Most of us, even those who don't have a stomach, usually don't go well with beans. But beans has its own nutritional value. And maybe that is the only food that this person can afford to give that nutritional value. For example, protein. So what I usually advise them, when they are within their homestead, they can take the food. But when they are planning to travel, they avoid taking such foods because it will give them problems during their travel. I hope that is clear. Then I come to the, okay, I can go back to the first question about open wood and closed wood. Some of these closed wood and open woods are good indications for negative pressure wood therapy, which will help us to contract this wood very fast. And so the patient will take less time in the hospital setup, and will be able to close the wood either by secondary suturing, or if it is a wider wood, we do reconstructive surgery. Then about cost of training. At the moment, our training is going for 40,500 shillings for the 3 months. And the requirement is you have to be a clinician. You have to have a licensure from your relevant board. You have to have a certificate of training from a recognized institutes. And you have to have had some experience, like 1 year in the clinical areas. Because some of the things you will experience them in the clinical areas, and then you'll be able to apprehend when you come to class. I think I'm through.
Oh, thank you, thank you. I think you have responded very well to the questions that have been raised. And thank you even for unpacking for us the word clinician to the specific cadres that are actually registered by the relevant boards, so that the right personnel get the right training, and therefore we have the right outcomes for our patients and clients. Mary, I had a question for you, and I just saw at the beginning, you mentioned about, you showed us a sample chart that helps us in the assessment. The right wound dressing starts with the assessment, wound assessment. And I was keen to note that you showed us a sample document. This really goes a long way in ensuring objectivity in assessing the wound. Do we have such a document within this institution, the International Hospital?
Yes.
What is our practice?
Our practice, when we are training our students, we have a dummy wound care chart, which helps them to assess the wound. In our clinic, in surgical outpatient clinic, they have also the way they document their assessments. And in actual, the assessment form is to help you in documentation. And there are several parameters that you check. As I said, you don't just check the whole, which is the wound, but you do check the patient wholesome, holistic care. That's where you look at the location of the wound, the etiology of this wound, when did it start, which part of the body is it on, what is the size, what are the tissues in it, is this wound exudating, and how much is it exudating? If the wound has a cavity, you have to measure the depth of that cavity. And all these details, you have to document them in that chart. So it is easy when you have a formulated form in an institution, so that it can be used uniformly, both by our students when they are in the clinical areas, and also by the nurses who are taking care of these patients.
So thank you, Mary, for responding. There was a question on the nervous supply to the bladder, and I will take that briefly. And I just want to say that there are 3 main nerve supplies for the bladder. We have both the sympathetic and parasympathetic nerve supply that really ensures that there is coordinated function in terms of micturition, whether it is a relaxation or contraction of the muscles. So the hypogastric nerve is specifically, it causes relaxation of the detrusor muscle that promotes urine retention. So once that happens, the pelvic nerve, which is parasympathetic, will increase signals from this to cause the contraction of the muscle, and that will stimulate the urine let down, the micturition itself. We also have the epidural nerve, and this usually innervates the urethral sphincter, the external part of it, that provides voluntary control over micturition. But I know there's a lot that is around the nervous supply. I have not exhaustively mentioned all the nervous supply to that bladder control function. So that's an area for further research and study on our own. Now I go back to the questions. There are a few more questions. We are still within our time frame. And I appreciate the question on CPD points. This is for the doctors. I believe this will be addressed by our administrative person. He is here, Nelson will address that. There is this question by an anonymous attendee. How should people dispose the bio-waste from the negative pressure machine when it's been done at home? That's for Mary. How do we dispose whatever bio-waste is coming from the negative pressure dressing material? The next question, probably the second last one, is to what extent do you involve other family members in the care of a family member with incontinence? Again, wound care, due to the long duration of these wounds, some of them are prolonged, requires that people do this over a long period of time. So family involvement is key, and we'd like to hear something about that. I think the last question is about provision of slides for this TME. There's a way they are provided, our technical or personal advisors. I feel I have mentioned all the questions, and let's allow Mary to respond to the two last questions, and then we'll call it a day for today. Thank you, Mary.
Okay, let me respond to the family involvement. As I said earlier, most of these patients are stigmatized and they need a lot of emotional support. And when it comes to family involvement, as long as this patient is conscious and in good mind, you have to get a consent. Remember, we have our ethical, legal issues. You don't just involve the relatives without the patient's consent. Let this patient, like in the case of stoma, a patient with an ostomy, that is a patient with a stoma. Let the patient identify a person in the family or a friend who can help them at home. And then you go through this person, educate them on how to take care of this stoma, what is needed, the requirements, that is the supplies, so that they can be helping this patient at home as they are waiting to be reconstructed, the stomach to be reconstructed or reversed. For wound care, we said people with chronic wounds, they need a lot of emotional support. There is cost in the care, and so they need support system. And that is where now the family involvement comes in. And also patients with continence, it is very unfortunate that most of them might not get helped because they will not open up and say they have the problem until somebody else notices that there's a problem. Maybe this patient is getting wet, the clothing, or this patient is withdrawing from the community or from other family members, and they note that the reason to why they are doing that is that. So as I said earlier, most of the times, things to do with incontinence, very few patients will open up or come and approach a doctor or come like to our stomach wound and continence clinic and say they have a problem. Recently, we have started seeing even men coming to us for help, where they can get the incontinence pads. And we really feel appreciated that there's some sensitization which is being taken to the community, and they are able to come to look for help. So involve the family members, involve the friends only when the patient has consented, unless the patient is having cognitive issues. The rest of the patient should have a consent and an informed one.
Thank you, Mary. The emphasis is informed consent because of what is involved. Allow me, participants, just respond to a question that was asked in a different way. The anonymous attendee was asking which nerve is responsible for sending signals to the brain about full bladder. So I think I answered differently. But when it comes to the full bladder, the pelvic nerves are responsible for informing the brain that the bladder is full and therefore elicit the appropriate response. Thank you so much. Unless Nelson, you have something for the participants, I would wish to end it here. And we want to take this opportunity to thank all of you. Mary already did a lot of acknowledgements to everyone that makes this presentation possible. And I just want to echo her acknowledgement that the hospital management is really a key driver in this particular process of disseminating knowledge. Yes, I am seeing basically there's a question. Thank you, Nelson, for alerting me. And how does the clinic help since dressing is very expensive and sometimes they don't come for dressing or stomach care due to money? Good question. I just noted down before Mary prepares to, as she prepares to answer that question, the challenges she listed here, that is one of the challenges. The cost of wound care dressings and those materials is prohibitive to some of our clients. Do we have solutions for this? Yes, Mary.
Yes, we do. When the patient comes to our clinic and we do a comprehensive wound assessment and we identify what we need. For example, if I feel that I have done the assessment and I feel that this patient is having infection and I need to control infection, we usually say that we don't use systemic antibiotics when the patient does not have systemic signs and symptoms. So we use topical. When it comes to topical, most of our dressings have silver. We have silver, we have copper, but the most of our dressings have silver. And so in the dressings that have silver, we have several of them. Some of them are not so expensive. And since they are going to help me achieve the goal of controlling the infection, I will go for the cheaper one, which the patient can be able to afford to pay for. And also the hospital, because sometimes we get vulnerable customers like the street families. We have a system on how the hospital waives them so that they can get the services like any other person outside there. So those are some of the things we do. When it comes to stomach care, we had a support group where we were able to give our patients some supplies. Unfortunately, we don't have a donation at the moment. What we give them is just the education. But when we have donations, we chip in and we distribute some bags when they come for the support group.
Thank you, Mary, for that appropriate response. Yes, challenges are there, but they are there to be overcome. And therefore, for every challenge, it is for us as team members and stakeholders to navigate and see how to help our clients be able to receive this very, very important service. I would wish to allow Nelson, you have a comment concerning the CPD. Again, a very small question there. Where at KNH can a person with incontinence issues seek for care? May you tell us about the clinic?
Okay, we have a stomach, wound and continence clinic in our institution, clinic number 24, which is also serves as the surgical outpatient clinic. When you come to that clinic, you don't have to line up at the medical records. You go straight to the clinic and you'll be attended. Most of the times we send these patients to our physiotherapy department for assessment, the pelvic assessment. And then we, after taking the history and we feel that they need a pelvic assessment, we send them to our physiotherapy department. The others that we send to our gynae reproductive department, because there is also services there which goes on for fistulas. So anytime you come, you'll be helped. You'll be directed. If it's something that can be taken care at the clinic level, they will do it. If it is something that is beyond them, they will refer to the appropriate person.
Thank you for today. I think we will call it a day. Participants and everyone who has made this possible, asanteni sana. CPD code, Nelson.
Yes, thank you to our nursing team for the wonderful session that we've had today. Just a small update on the CPDs. Kindly note that regular updates are included in your reminder emails as per CADA. So you could go according to your CADA, see the instructions that have been put for CPD. We also have CPD requirements, there's that minimum requirement, and also our registration page or rather form includes areas where you can input your cadres according to the boards or council you belong to, and we'll be able to process CPDs from our end. Just to mention, we have just received accreditation from the KML TTB, that is the board for lab technologies. So kindly lab technologists within the call, kindly let your colleagues know about this so they can be able to join our webinars and get the CPD points for those. If you have any queries, kindly direct them to our email address. That is knh@knh.co.ke. That is knh@knh.co.ke, and our support team will be able to assist you. Thank you once again for joining us today. We will be having a session, or rather a continuing series that is in data analysis tonight. The poster is posted on your screens, and the link to that is also on our registration page. You can get it, and you can also share with the colleagues who will be interested in this session. Thank you once again for joining us. Do have a wonderful afternoon and good day.